for hypertrophic obstructive cardiomyopathy, it's important to find the highest peak gradient. In this specific case, let's review all the gradients we have at hand. Initially, we started with a resting study. We had a peak gradient, you can see it here, around 15 millimeters of mercury, a little bit less than 2 meters per second Vmax, so the maximum velocity was not that high, but already you see some kind of a gradient. Now, using what we have to do by means of stressing the LVOT, the patient, we use the Valsalva maneuver. Now we have a little bit of a higher gradient, around 60 millimeters of mercury, again, roughly 2 meters per second Vmax. So it's definitely not a significant gradient. If you do not achieve a high gradient in a patient with symptoms, this patient was already under Mavacamten, so a myosin therapy, and you believe that there's a higher gradient, use different modalities. In his case, we used a balloon Valsalva maneuver. So we let him inflate a balloon, and when you do that, you can see that the gradient is already significantly higher. We have a peak gradient of 30 millimeters of mercury. We were not convinced that that is all, basically, so we added another session of the balloon Valsalva maneuver, so we let the patient inflate the balloon also several times, really with peak inflation, and with that we reached a gradient of 50 millimeters of mercury, almost 50 millimeters of mercury. So even though the patient has already Mavacamten therapy, we probably need to increase the dosing. That's what we did, and already the patient felt better. So we are curious about the follow-up. Furthermore, the Valsalva maneuver is not that easy to perform. The balloon Valsalva maneuver is, from our experience, easier for the patients to understand. They can inflate the balloon properly, and then you reach a higher gradient. So if you're interested how this is done, let me know in the comments, and we will show you how to perform such a balloon Valsalva maneuver.